what is a shared decision tool, right? Basically, it's something that's designed to be used with the clinician and with the patient and the family together. And then we've kind of condensed that all into a free online tool that hopefully any surgeon in the U.S. can use. We try to keep the overall course of scoliosis treatment like under 1 year annual background radiation, which is like 3 millisieverts. So I've done a lot of work trying to reduce the amount of radiation from either intraoperative CT or preoperative CT, and we found that using special settings on these machines, we can drop the radiation to about 1/6 annual background radiation. Well, I have learned how to mountain bike.
I live in Boulder, Colorado. Everybody mountain bikes. And
Yes.
my spine surgeon friends there say that mountain bike injuries are the #1 source of trauma cases they see. More than
All right.
skiing, more than anything else.
Okay, maybe I'm giving up mountain biking.
Voluntarily going out in the mornings when it's 10 degrees out to go for a run. I would say she is hardcore and I would do it, but no.
So she's more hardcore than you are.
Well, I'm not going to concede that.
Hey everybody, we are back with another episode of Back Talk. I'm excited to introduce our guest for this episode, Dr. Noelle Larson. She is a professor and a surgeon at the Mayo Clinic and was recently promoted to Division Chair of Pediatric Orthopedics. She also chairs the research committee at POSNA and is involved in several other research endeavors, which she'll tell us about as we get into the episode. Really excited to introduce you all to Dr. Larson. Welcome to the show.
Thank you for having me, Rebecca.
Yeah, we're excited.
We're very excited you're here. Welcome.
Thank
And
you.
congratulations on the new promotion.
Well, it's interesting because my facility where I work at Mayo has term limits. So about every 10 years, all the leaders turn over. So it was my turn.
Oh, interesting.
Yeah, I think it makes sense. I like it.
That's good. It sounds like a wonderful leadership position for you. But I'm curious if you could start for us. How did you end up where you are today? You're at a top location for surgery in the world. You're doing these incredible cases. But where did it all start? How did you decide to be a pediatric spine surgeon? And who are some of your mentors along the way?
Oh, well, that's a great question. And it's been a long journey. Actually, I was born the child of a boat builder. So my dad worked in a boatyard, and he built a 65-foot ferrocement boat. So I came from the hospital, and actually my first 10 years I lived at Jensen Motorboat Company in Seattle, Washington, right on the Montlake Cut there.
Wow.
So I always had a very much a mechanical predisposition and studied physics. And for a while I thought I was going to become a geophysicist. But I came back from a summer National Science Foundation sponsored internship and decided I really didn't like it. And my physics advisor at the time was Robert Laughlin, and he had actually named all of his computers, and he had them all named. And actually I caught him once when one of his computers had crashed and deceased, and he was actually crying about his computer. So
wow.
Anyway, but he was very supportive of the pre-med pathway. And so I think that was one of my first big forks in life, right? To go into medicine instead of physics. And I'm really thankful I did, because there's really like no better job in the world than being an orthopedic surgeon and being able to see the direct impact of your care. But I think that helped me to have this mechanical background and this kind of familiarity of the quest for the truth. And I've enjoyed it.
Were you an undergrad when that pivot happened?
Yeah, undergrad.
Interesting.
So then I went off to medical school, University of Washington, found orthopedics, and then all the places that I went for residency interviews, the one that impressed me the most really was Mayo Clinic. And I felt like I'm going to be the best surgeon if I train at this institution, and I want to come here. Luckily, my fiance at the time agreed, and then we've kind of pretty much been there ever since, off and on for the last 20 years.
Wow.
Wow.
Congratulations on that career.
It's amazing. It's an amazing place, and I've had a lot of amazing mentors. I did my fellowship at Texas Scottish Rite with Tony Herring, amazing, kind, warm individual and surgeon, Dan Ciccato. It's been quite a journey.
Yeah.
Todd Milbrandt, I guess, is my most recent mentor and previous division chair and current POSNA president, and he's been very impactful as well.
It's fantastic. So speaking of Posna, you're the research chair. Tell us a little bit about that. What does that entail?
Oh, it's been an amazing journey. So basically, I have served on the board for the last 3 years, and I work with the research committee and the evidence-based practice committee and basically follow Posna's strategic plan. So we've had 3 main initiatives that we've done in the last 3 years. One was to kind of increase our relationship with the Orthopedic Research Society and to reach out to clinician scientists and also reach out to career scientists. So actually, POSNA was guest society at Orthopedic Research Society in February. So we had about 20 POSNA members and 3,000 ORS members, and we were there for 3 days, and we did a symposia, we did a keynote speaker, we had a booth, and we had these undergraduates actually coming up to us saying, we want to join POSNA, and we're like, well, you have to be an orthopedic surgeon first. But there's just a huge potential, I think, to start working with more of the career scientists and attract more talent to pediatric orthopedics in order to drive research forward. The second thing we did is in 2023, we actually got an email from the NIH asking us what are POSNA's top research priorities. So we actually did a survey of the membership using a Delphi process, and we were able to develop a consensus-based research agenda. So I just announced this 2 hours ago. We have 16 questions that we've decided are the top research priorities for the 1,700 pediatric orthopedic surgeons in North America.
Wow.
And we're going to write to Department of Defense, NIH, all of our funders, maybe to our industry partners as well, and tell them what the questions are. I'm really excited that we've kind of come to that point, and now we get to try to answer these questions, right?
It's amazing.
It is amazing. And then the third thing we're rolling out, do you want to hear? Is it
Yeah.
getting too long? Okay, the third thing that we've rolled out, so we're rolling out a surgeon quality improvement database. And the goal is to develop prospective quality data for scoliosis. We have 2 modules that are rolling out. So one is scoliosis fusion, and the other is scoliosis non-fusion or tethering. So there'll be 2 prospective quality registries that any surgeon in the U.S. could join.
And then what is the process? I'm curious for them to join that type of registry.
Well, we're partnering with Studying Scoliosis Straight Foundation, and they already have a surgeon improvement program or surgeon performance program. So we're partnering with them and expanding upon that. The current program has only 3-month follow-up, so we're going to try to push it out to 2-year follow-up. The limiting factor, as you'd imagine, is data collection, right? So how do we collect data? So we're looking at different avenues for automated data collection, passive data collection, so that we'll have an ability for more surgeons to participate. Peds Ortho is quite unique because there's all these wonderful research consortia, but it takes a lot of resources to participate in a research consortia such as Setting Scoliosis Straight Registry or Pediatric Spine Study Group Registry. So we're trying to lower the bar, make it easier for more people to contribute data, and then we learn more.
Yeah.
Well, you know, whether it's evidence-based medicine or collection through these registries, the more data we bring in is interesting, especially in this era right now with the large language models and what AI and deep learning can do to mine that data, but we know that can only happen with the good data in originally. So all this work you're doing is so critical to that, and then the ability to refine that and do the analytics, but it's going to be very interesting. So those types of initiatives are just so important.
It was a great time, and we had a lot of fun. So I got to be on the board for 3 years, and I met all the other amazing board members, and POSNA is a top-notch organization.
So here's a question I bet our listeners would be interested in. When you do that, you're running your practice at Mayo, how much time do you spend on a board like that with POSNA? Like, how much of your time does it take as it relates to, and with Setting Scoliosis Straight work you do? Like, how do you manage that around your broader practice?
Well, I'm fortunate to work at an academic institution, which is supportive of academic activity. But at some level, I start taking days that were vacation days and turning them into trip days. But it's about 10 days a year to serve on the POSNA board. It's about 7 days a year to be a member of Setting Scoliosis Straight Foundation, and probably about 20, 25 half-day or 2-hour Zoom calls a year. So it's quite a big chunk of time. It's a lot of dedication to be able to participate. But at some level, I love the daily gratification of taking care of a patient and helping a family through scoliosis treatment. But I want to scale that. And if I learn something in my practice, I want to share that with somebody else. And that's what I kind of view research as. It's a way to share information and work towards better outcomes.
Yeah. That's amazing. Setting Scoliosis Straight Foundation, I know that the industry partnership, selfishly speaking, it helps us too, and it's been really nice to just get to know the surgeon community and kind of partner up to move things forward together. How do you view the industry partnership in something like either POSNA or Setting Scoliosis Straight? What do you look for in an industry partner to help with that?
Well, I think at the end of the day, orthopedics is still heavily dependent on implants, and I can't go into my basement or I can't go into the hospital basement and print screws or cords or rods to use. And we're really reliant on a complex infrastructure of engineers, biomechanical testing, data approvals, data collection, in order to actually bring an idea to a patient where it can actually be used in the operating room. So I think orthopedics is one area where we really need to work closely together to move the field forward. And I think everyone from POSNA, which is our National Peds Ortho Society, to Setting Scoliosis Straight understands that there needs to be a process of working together. I think as far as all the research consortia, from my observations, both doing a surgeon-sponsored investigational device exemption study, doing an industry IDE, like the ability to collect data can be done at much lower cost than a classic industry IDE using research consortia, and potentially higher quality.
I would agree. I mean, again, it helps us to work with a group of surgeons who are skilled at collecting that data. And it's also easier and I think a lot more credible too than us trying to go it on our own. So yeah, there's definitely a symbiotic relationship I've always felt between surgeon societies and research groups and industry. So it's fun. It's fun to put our heads together and see what we can do together.
And pediatrics really is an unmet need. It's hard to generate enough data to justify a new pediatric implant or a new pediatric product because the market is so small. So the cost of getting the approvals and getting something approved by the FDA is more than a company might ever make on that product long term. So whatever we can do to lower barriers and safely get new innovation to patients is really one of my career goals.
Yeah, it's great.
Fun.
I have another question around research because it's such a hot topic for you. I know, and I'm gonna get the decision-making tool that you have developed for parents who are trying to decide a path of treatment.
This was really an amazing story. So it's actually how I got involved in Setting Scoliosis Straight Foundation. So Michelle Marks, who's their executive director, and Peter Newton, Sukin Shah at the time, were working on a grant to the FDA, and they wanted to basically understand what patients cared about, whether patients and families cared about motion, do they care about correction of the scoliosis, like what are patients' values when they go into a scoliosis surgery. So I helped Michelle and the rest of Setting Scoliosis Straight Foundation to write this grant to the FDA. We were awarded the grant, and then we were halfway through the process of just doing basically a complex survey study where the FDA talked to us and said, hey, can you do a shared decision tool as well? So second part of the grant was to work with Mayo Knowledge Education Research Unit and develop a shared decision tool to help families make a decision more reliably and using the best evidence available. So what is a shared decision tool, right? I should probably let you know what that is. But basically, it's something that's designed to be used with the clinician and with the patient and the family together. And it's like a series of slides. It's almost like a PowerPoint or graphics where it's showing data about the procedure, risks, benefits, alternatives in a user-friendly, patient-friendly mode. Mm-hmm. And I think that's the goal of my patient encounters, is to empower the families to decide what surgery is best for their child.
And what have you found is the most, I guess, driving factor in making that decision? Does it vary by patient and parent, or is there some consistent trending and feedback that comes out of that?
We did a survey of over 300 families, and half were still thinking about whether they wanted to have a fusion or vertebral body tethering. The other half had either already had a fusion or vertebral body tethering. And it turns out that patients that wanted to have vertebral body tethering cared about motion and quick return to activities, and patients and families that had a fusion cared more about correction and less chance of having additional procedures. So people are picking the right topics, and then we've kind of condensed that all into a free online tool that hopefully any surgeon in the U.S. can use when they're talking to families about vertebral body tethering.
It's fascinating. It's great.
It's going to be great.
Yeah.
Are those grants still in process? Are they still being funded?
We are completed. We did put through another grant, but I think the climate is a little bit dicey at the moment. But we can hope to continue the work. The next step, again, kind of under the shared decision tool research roadmap, is to do a randomized control trial. So you'd randomize conversations to using the tool versus not using the tool and see if it changes decision making.
Very interesting.
We found using the tool, the patients talked a little more. So oftentimes it's the parents and me talking and talking and talking and talking. So using the tool got the child to interact more in the conversation and to ask more questions. And we found it took 3 minutes longer, which is not bad for like a half an hour visit or 45-minute visit, 3 minutes longer to use the tool.
Yeah, and hopefully give everybody that informed consent so they're making a decision with all the factors considered and weighted and letting the patient weigh in too.
Absolutely.
I think that's huge.
And we assembled a panel of scoliosis surgeons and we did a literature review and took kind of the best available literature to put into the tool. And we'll repeat that process. So as more literature comes out, we can update the tool.
Yeah.
Okay, so I'm going to ask you, all this impressive work you're doing, you know, you must be working constantly. What do you like to do when you're not working? What do you do for fun?
I like to try to run in the mornings, but it's really contingent upon me not having a 6 a.m. meeting. So this is one of the things I want to do as pediatric division chair, is try to reduce the number of 6 a.m. meetings. So it's quite hard to run and make it to work and get your hair dried and washed and get presentable by 6 a.m. and run. So I like to
where
run.
you live. I mean, that's chilly.
I like to run as long as it's like above 10 degrees outside. Below 10, I don't run outside.
So if it's 10 degrees, you'll run?
Yeah, I think 10 and up.
10 and
Inclusive
up.
10.
That's pretty hardcore.
But I don't run very far. I run like 2-3 miles. I'm not a marathoner. And then my kids have picked up mountain biking. So I have learned how to mountain bike, and I just got a dual suspension, which makes it so much easier.
Yeah.
I'm like a whole level better having a dual suspension.
Wait, so you're an orthopedic surgeon, right?
Yes.
And you're aware of the fact that when you're mountain biking, at some point you're probably going to go over the handlebars.
I mountain bike pretty slowly.
Okay, all right.
So I live in Boulder, Colorado. Everybody mountain bikes. And
Yes.
my spine surgeon friends there say that mountain bike injuries are the number one source of trauma cases they see. More than
All right.
skiing, more than anything else.
Okay, maybe I'm giving up mountain biking. It's too depressing.
I know. But to your point, if you do it safely, you know?
It's
we
fun.
tend to go, so we've gone to Arkansas. So for a while, my husband was on this road trip bent for a long time. So we were only driving to vacation. So it's a 10-hour drive from Minnesota to Arkansas. So there's good mountain biking in Arkansas. And then we go up to northern Minnesota, where it's beautiful mountain biking.
Yeah.
But I think that's not the same. Like, we looked at the Utah, Colorado destinations once and kind of decided not to do it. Well, there's cliffs, like real cliffs.
Yeah, it's
Yeah.
intense.
Yeah, I think I'm kind of more of a hiker. I'm a Utah, Colorado hiker and
So
a
am
Minnesota biker.
That's great.
Okay, I like that.
Yeah, that's great.
But
So 10 degrees, how often in Minnesota is it worse than 10 degrees in the morning?
not very much, like 2 weeks a year,
Okay.
3 weeks a year. But I don't run every day. I really should, but I don't.
Yeah, that's great. Again, Boulder, Colorado, so I'm spoiled. If it drops below 40 degrees, I feel like it's freezing.
Well, Boulder has like lots of beautiful outdoor options, so.
Yes.
And
that's
good
true.
restaurants.
Yes.
Yes.
Very true.
It's good.
Very true. So tell us a little bit about your patient population and kind of your philosophy in treating these kids when it comes to just the different options that are out there.
I really love taking care of young people and their parents. And really, it's not just one person in the room, it's the whole family. And so I think the first part of the visit is really understanding who's in the room, what are their values, what do they know about scoliosis. Scoliosis can be an absolutely devastating diagnosis because many times it's a healthy child. No one knew the child had scoliosis, and the family has suddenly had their life completely disrupted, either to think about bracing or therapy or surgery, and they're trying to wade through all this information. And it's also oftentimes a teenage girl at a hard point in life where there are sports or activities or friendships or academics. So it's challenging.
Yeah.
But I embrace that challenge and jump right in, and every day I'm impressed by how brave my patients are and how brave my families are, and I try to get patients through the process with like the least possible impact on their life.
So if
Right.
we have any patients or parents listening into the podcast, what would be some advice that you give patients the first time they come in and their child was diagnosed with scoliosis? Just how to think about the journey they're about to go on.
I mean, I always emphasize it's a very treatable condition. So we're lucky it's a very treatable condition and the outcomes are very good. I think if we're looking down the bracing physical therapy, non-operative route. We kind of talk about it being something that's kind of a small impact on your life every day for 6 months or a year or 18 months. And we try to strategize. I try to figure out what is going to be the problem point, what's going to be the pinch point, and we try to decide what bracing plan makes sense for the child. Similarly with surgery, if we're at a surgical magnitude curve, I'll try to find out what the child's activities are, what their values are, and what route would be best for this family. But ultimately, I do get the complaint that, Dr. Larson, you didn't tell me what to do. And ultimately, I feel like my goal is to really inform patients, and then they have time to think about it and decide what's best for them. But there's so many great surgeons in the U.S. There's so many great care providers, and I think I'm in a field where we're small enough that many of the surgeons all know each other, and we're often working together to try to make care better.
So, Dr. Larson, we've seen a lot of changes in our education system. One of the things that's been interesting, we're seeing a change with less focus on nurses in the schools. And as we all grew up, the nurse would check us for scoliosis, going through a physical education, and that would be a point of picking up through the process. And I'm just curious what your thoughts are on that. If it's something that we should be thinking about, it's a concern, or you think that their family practitioner is there to pick it up?
Yeah, there were amazing school screening programs in place really throughout much of the U.S. Unfortunately, our county had a study that was published in JAMA, which is the top medical journal in kind of the early 2000s, and they felt through this article that too many children were being x-rayed. And at that point, there was concern as to whether braces are effective at treating scoliosis. In the meantime, we found that bracing is very effective for treating scoliosis. But I think once the building has been unbuilt and all these school screening programs have been disassembled, it's hard to bring it back into practice. We looked at our county, which has a population-based registry, and basically found that we were seeing fewer patients. So the number of patients coming in our county each year for scoliosis had dropped 50%. The year that school screening ended.
Wow.
50%.
50% drop.
Whew.
Our county's small in Rochester, Minnesota, so we couldn't show that there's a higher rate of surgery as a result, but there is compelling data from Hong Kong showing that the school screening programs reduce the rate of surgery. So I think it's probably too much to ask the public schools right now to go back to school screening. We really rely upon physicals, and it's caught frequently in the sports physical. But I agree, we need some kind of population-based screening option where scoliosis can be detected early and then hopefully treated.
Interesting.
Very interesting.
Let me ask you another question because of something you mentioned. Talk about radiation and imaging as it relates to the pediatric population, both during the life cycle of the x-rays and also intraoperative, the different types of imaging modalities, and what your thoughts are.
Absolutely. Well, I've published a lot on this, so I'm just citing the work that we've done, and I've worked closely with our Mayo radiation physicist, and that's been really the key part of studying all this. But historically, National Scoliosis Cohort, and then there's data from Dr. Simone out of the Netherlands, basically showed high rates of cancer in children who had been treated for scoliosis. Now, those kids were getting more radiation on the order of like 3 times annual background radiation or more. So nowadays, we try to keep the overall course of scoliosis treatment like under 1 year annual background radiation, which is like 3 millisieverts. You guys live in Colorado, so you guys get like 6 millisieverts a year because there's more radiation in Colorado.
Really?
Yes, you're higher elevation, and then the rocks have a little bit more radiation in them. But in general, many people are using slot scanners. So for routine scoliosis care, there's biplanar slot scanning imaging, a couple brands of that available right now. Those significantly reduce the dose, somewhere on the order of 50 to 80%. If you don't have access to a slot scanner, you should always be getting a PA x-ray, so the beam should be aimed at the child's back, because then that protects the radiosensitive organs like thyroid and gonads from the beam, so that drops your exposure by quite a bit just by shooting the image from the back. I think the big elephant in the room always is CT scans. So one CT scan can be 2 times annual background radiation. And if you have 2 CT scans, you're getting to this level where historically we've seen higher cancer incidence. So I've done a lot of work trying to reduce the amount of radiation from either intraoperative CT or preoperative CT, and we've found that using special settings on these machines, we can drop the radiation to about 1/6 annual background radiation, which I think is safe. Like a traditional scoliosis X-ray might be like 0.6 millisieverts. A chest X-ray is 0.1 millisievert. So if you can keep the CT scan kind of under 1 millisievert, that seems very safe to me. Plus, you have the added value of knowing exactly where the implants are going at the time of surgery. So I believe in navigation. There's good data to support it, but it may not be feasible everywhere.
Got it. Very interesting.
Sorry,
Thank you
that's
for
a whole
that.
other hour.
Yeah, would love to have that conversation.
Oh, let's do it. I love to talk about navigation.
Yeah.
Yeah, it's been great, and there's so much optimization we could do.
So you're very passionate about motion-sparing technologies and treatment paths, which is fantastic. Talk to us a little bit about how you see that benefiting the child and why you're such a big believer in that.
Well, I think, Rebecca, it follows from wanting to have the minimal impact on the child's life. Like if we're going to brace, I want to do a nighttime brace when we can because I want to have the minimal impact on the child. And I got very excited by the motion-sparing scoliosis surgeries because it seems that the patients don't feel a big impact on their day-to-day function after motion-sparing scoliosis surgery. Somebody with a fusion down to the lumbar spine or the lower part of the back, it's going to change how they move in space and how they roll over in bed and how they reach up into the closet and grab their dress shoes off the shelf. It's going to impact their sporting activities. Unfortunately, in the literature, we haven't quite captured all that. I don't think we've really captured the full difference between motion sparing and fusion, particularly in the thoracic spine. So I'd say in my next 3 years, that's one thing I'd really like to see and really like to participate in is research to prove a functional difference between motion sparing versus fusion scoliosis surgery.
So your early experience has been a dramatic difference between the children that have been able to have motion sparing versus those with fusion. And where do you think we are in that timeline of the general population understanding that, the general surgical population?
I think we're at the point where fusion into the lumbar spine is starting to be seen as something to be avoided. Certainly being fused to L3 or L4, which is your lower lumbar back, puts you at higher risk of getting arthritis 20, 30, or 40 years down the road. I think the 30 and 40-year outcomes for a thoracic fusion versus a thoracic tether are still forthcoming. But in my mind, let's preserve as much as possible, right? If we can preserve thoracic back bend, the ability to do a back walkover, the ability to do a hyperextension, like let's preserve it. This is a 10-year-old or a 12-year-old. The other interesting thing to think of that's a little outside of the box is think how much society has changed in the last 20 years. Like there's motions that we do and places that we sit and ways that we move that we didn't used to do.
That's
like,
interesting.
I never thought about that.
We used to, if people had an elbow dislocation from birth, like we used to fuse one hand up and one hand down, but now you really would want to fuse maybe in a position where you could use a smartphone, right? Or again, who knows what we're going to be doing in 20 years? Maybe we'll need the ability to do more hyperextension. Or maybe this child that right now is a couch potato and not very active might decide that they want to be a triathlete. I know people who've become very active later in life. Yeah. And to have done a long fusion, especially into the lumbar spine, and potentially limit that child's activities 20, 30 years down the road. In my mind, the slightly less correction and potentially slightly higher chance of a second surgery are things to weigh against having a permanent fusion procedure done.
It's a great perspective.
Well, I've thought a lot about it.
Yeah. And you're very well informed and experienced in the space, so you definitely know what you're talking about.
Well, I'm trying to be, realistic, but also we have to look for some of the amazing results that we are seeing. Like we see some really amazing results with the tether, not 100% of the time, but 70, 80% of the time. And how do we encapsulate those amazing results and make that the result for 98% of the patients?
Very interesting. Well, as you continue to go down that path and do research, we'll have to have you back on the podcast and hear how you're progressing.
Is there any one patient or case or experience that stands out when you think back over your career, either exceptionally challenging or exceptionally rewarding? Or
Well, I've kind of been trying to offer motion-sparing scoliosis surgery to my patients for a long time. And so I'm very impressed by the patients who come in and know that this is early in my experience or our institution's experience or the nation's experience. So some of the patients that have been the first people in our studies, like, they know that. I tell everybody, you know, you're this patient, you're that patient. I've had people print up T-shirts saying,
Wow.
I'm patient number 13.
Really?
Oh, wow.
Yes, so I'm very transparent, and I think it's very brave of families to be willing to trust me and trust my institution, trust the device company, that we've all done a good job, and that this is ready for prime time.
How often do patients, in your experience broadly, have done research ahead of your first visit? They've been on the internet, and the other part of that question is, do you find that helpful or not helpful when they've gone down the path through the rabbit hole of their own research?
I think my most important thing is just to figure out where they are at in the process. And you can tell if you're starting to talk and someone's overwhelmed. I'll find a way that will, like, let's visit again. Let's do a video visit in 2 weeks. Let's do a video visit in 3 weeks. I find it almost easier if people are more informed and they've done some reading and they've thought about it, and it's not that first initial gut punch of, oh my gosh, my child has a serious condition. So I try to spread it out. Most families, if that's the first day they're learning about it, they're not really ready to process it, which I think is understandable.
Sure.
Yeah, the informed healthcare consumer, I mean, that's a trend we've seen continue to grow. I know in my own personal life, whether it's a family member or myself, I'm somebody that likes to show up informed.
Yeah.
And I think that, especially in the case of something like teenage scoliosis, that is something that parents, at least from our experience, we see that happening a lot. And so I think, to Eric's point, is it helpful or harmful when they show up with information? I've had surgeons tell me that at times they have to actually kind of backtrack some of what's been maybe wrongfully concluded on the part of the research.
No, I love informed patients, and I love to engage the patients and the family and the parents, and I learn a lot of things about it. And frankly, I don't have a patent on knowledge. Like, there's all kinds of knowledge out there that we don't understand. Like, why does acupuncture work? How do you cure back pain? I think from a medical standpoint, like, I just understand one little part of the elephant, and there's a lot of other parts out there that aren't uncovered yet. So I learn a ton from my patients every day, and I'm happy to listen to whatever they have to bring to me.
Are there any certain websites or sources that you direct people to get basic information that you feel are good sources of information for patients?
Well, absolutely. There's OrthoKids through POSNA. There is Scoliosis Research Society has very well-developed education pages with a lot of text. The Setting Scoliosis Straight Foundation has a lot of patient information. But I agree, there's this sense that with scoliosis and the diagnosis of scoliosis, there's a sense that you're alone. And a lot of people feel alone and feel like they don't have people to talk to about it. I told this story before, but like I travel a lot, as we talked about, and like I'll be in a taxi or taking public transportation, and someone will say, "What are you doing here?" or "Where are you going?" And I'm like, "Well, I'm going to a scoliosis meeting." And they're like, "Scoliosis? Is that a thing?"
Really?
Yes, there's a sense in the world that it's not as that it's old-fashioned or not acceptable to talk about. And I'd like to tear down all those stigmas. And for all the young ladies out there that are like struggling with scoliosis, like, you are not alone, and you're going to make it through this, and there's a good future for you.
You know, we had a patient actually come speak at a town hall a month or so ago, 13 years old. She was amazing. And telling her journey, I think you just get a whole new appreciation for what these kids go through. And every single time we have that touch point, I think it just sends the message home yet again that what we do is very impactful. And we're not even the surgeons, but having a small role to play in hopefully assisting surgeons like yourself with the right tools, you know, it matters. And to your point, these kids, they need that sense of community. This young lady had actually started a charity where she wanted to basically give back to other kids with scoliosis. And it was a toolkit to help them through the process that she did herself as a 13-year-old. It was a pretty compelling story, very impactful. Our team members are still talking about it. It was great.
It's amazing. These young people are amazing, and hopefully they'll come out and become orthopedic surgeons someday.
Yeah.
They can take care of us.
Absolutely.
Exactly.
Absolutely.
And I think it's a silver lining to the cloud, right? No one ever wants to be diagnosed with scoliosis, but it is a way to build resiliency and to build leadership skills. So yeah, the young people are absolutely phenomenal. And then I get to see them like when they're 10 to 12, and then they'll come back at 18 or even a video visit at 23,
Yeah.
and I can hear about their lives. It's really a privilege to do what I do.
It's fantastic. Well, you're so good at it, and your passion for research is inspiring and much needed in this field. So, yeah, I just think you're making a big impact.
Well, I have lots of great colleagues and partners and culture. I think Peds Ortho has a great culture, so I think that helps us move forward more quickly and hopefully find a cure to scoliosis.
So let me ask you a different question. So if there's a medical student listening right now, and they're about to finish medical school, go into residency, and you look back on your impressive career, what's some of the advice you would give to somebody just entering medicine, finishing medical school, and starting this pathway of residency?
I think you want to enjoy each day. People look at the numbers of years of training or the various pinch points to find a residency job. Even getting into medical school nowadays is a real challenge. But just enjoy each day, enjoy the journey. You're going to be learning. These are good years as you go through your training. And then I'd say be an aggressive learner. Like, don't be afraid to ask questions. Leave space in your life to think about questions each day. And then don't be afraid to try and answer them, because there's a lot of work left yet to do. And I think we want to move the field forward.
I love that. That intellectual curiosity is huge. Aggressive
Perfect.
learner. I'm going to remember that.
Yes.
Love it. Love it. That's great. Well, this has been wonderful. Thank you for sharing your insights and your career and your perspective with us. It's been just a real pleasure.
Well,
Very
thank
impressive
you.
career.
Thank you for supporting scoliosis and scoliosis treatment, and it's my pleasure to be here.
Absolutely.
Thank
Dr.
you.
Larson, thank you for being on Back Talk.
Thank you.
Thank you for joining us for another episode of Back Talk.
We'd like to thank Dr. Larson for her hot takes on spine.
Thank you.
Cheers.
Cheers.
So another great interview. Dr. Larson's amazing. What'd you think?
Isn't this fun? I think we're so fortunate to be able to have just this nonstop flow of amazing surgeons that we just get to talk to. I thought she was great. I've known Dr. Larson a long time, spent time in her OR, and also she's been a great industry partner to just basically help us further research. I loved her take on research. I love how passionate and committed she is. She clearly cares very much, as do all of these pediatric surgeons. It's really special. It's a special group, like she said, but really enjoyed hearing her take on research specifically. I thought it was wonderful.
Yeah, it was great. You know, the one takeaway that I hope anybody listening today is that if you have a child with scoliosis, this is a treatable condition. It's scary, but it's treatable. And I thought that just, to me, is a huge takeaway from a top surgeon at Mayo. When you're a parent going in and you're scared, you don't know what to expect, that's probably the number one takeaway for me, is that anybody listening today or trying to understand that there is a solution here.
Yeah, totally agree. And I think Dr. Larson does such a nice job informing not just the family, but the patient also, to try to stay ahead of the curve. And I think that early detection and that early intervention is so critical just to preserve optionality. And so often we see patients time out of a certain treatment path, either because they're not fully informed early enough, or they want to hold on to hope that maybe surgery isn't necessary. So I think Dr. Larson does an excellent job threading that needle and just making sure that she's providing all possible options at the earliest point in the process. It's great.
Very impressive. I found her to be very impressive.
Yeah.
You know, our last couple episodes, we've had a number of surgeons in the scoliosis space, a lot of pediatric doctors, and I think, as we build out our episodes.
Yeah.
And it'll be very interesting to think about these interviews. And as we're starting to now interview more doctors in the adult degenerative space, minimally invasive, some of these other newer technologies, talking about robotics. She did touch on imaging navigation. It'll be interesting because we'll be able to go back and see what the differences are on how these different surgeons approach the way they think about patients and treat patients and research and so forth.
Yeah, totally agree. It's going to be fun to continue to expand the different types of surgeons that we bring onto the show. So looking forward to that, because there's so much out there. We're just scratching the surface. I actually have a hot take question for you, and that is this. She mentioned the fact that she runs every morning as long as it is not below 10 degrees. And my question is, we talk a lot about type 2 fun and having this grit and resilience. Mm-hmm. Is that something you're willing to do?
So I'm a big believer in type 2 fun. I like to go hard for a reward, whether it's climbing an enormous mountain. Being out in the cold is great, but voluntarily going out in the mornings when it's 10 degrees out to go for a run, I would say she is hardcore, and I would do it, but no. I'm going to go to the gym where it's not 10 degrees outside. That's hardcore, and
So
I probably am not going to do that.
So she's more hardcore than you are.
Well, I'm not going to concede that. But she probably is when it comes to going for a run in 10 degrees.
Fair.
Okay.
I'm spoiled.
Would you?
No. No, and
You live in the mountains, you live where it's cold. Would you go for a run when it's 10 degrees
No,
out?
I would not. All right, so hot takes in spine. I've got one for you, just based on the interview we just came off. I think I'd love to get your take on what's going on with imaging, navigation, radiation, exposure. It is a very hot topic, especially in the PEDS community. So just curious to see what you think is going on in that space and how we can continue to make inroads to solve a very relevant problem.
Yeah, I find it very interesting. I've recently, with a startup I'm involved with, been looking at, how can we provide best-in-class imaging with dramatically reduced radiation. There's a lot of technologies, looking at in this space of what we can do with imaging and navigation. It's clearly part of the go forward in the continuum, imaging, navigation, robotics. But the radiation exposure is a real issue. There's been some recent articles. She mentioned the research she's doing. There was a recent article that came out that really got a tremendous amount of attention around the association between cancer and CT imaging. And so I think it's a space that we're going to continue to see a lot of change, a lot of innovation. I'm excited about what we're doing, so stay tuned on that.
Okay, I'm curious.
But it's an exciting space right now. I will tell you that if you look at the surgeons trained today, it's clear that the younger surgeons coming out are focused on navigation and robotics. Now, you have to have imaging. You have to gather the image to be able to do navigation and robotics, right? And so the acquisition of that imaging has tremendous radiation exposure associated with it, whether it's at the time of surgery or preoperatively. A number of people are working on this space. But I do believe that navigation is here to stay. Navigation, for those listening, is really this concept of taking any surgical instrument and being able to, in a minimally invasive environment or open, meaning not sure exactly where I am, but looking at a screen within 1 millimeter of accuracy, I know exactly where the tip of my instrument is so that I'm placing it in the right place. I don't hit an organ or a vessel or something I don't want to hit. And we're seeing more and more surgeons coming out of residency and fellowships being trained in this space and utilizing these technologies. So how do we make those technologies less cumbersome, maintain an easy workflow, and deliver a solution? So I think there's a lot of companies looking at it in the space, and it's going to be interesting to watch. What are your thoughts?
Yeah, I think we're hitting that tipping point after watching this evolve for many, many years, decades actually. Like everything, innovation always takes longer to catch on than I think we would hope or expect from an industry perspective. But I have seen a massive uptick, in large part to your point, the younger surgeons being trained in residency and fellowship on these types of technologies now. So they're coming out and starting their practice with the expectation that will be part of their practice. And so I think as the surgeon population continues to turn over with new younger surgeons coming into the workforce, that will only continue to pick up speed. So I think navigation for sure is here to stay. Robotics, obviously very interesting as well. We always keep an eye on that entire space. But I've said for years, I think the real innovation is going to happen beyond the implant. So we need implant innovation too, and of course that's our bread and butter. But yeah, I'm fascinated to see, especially now with AI and deep machine learning and everything else that's coming to really its maturity, I would say. I think it's going to just catapult this part of the industry forward. And I'm excited about it because I think it will dramatically improve not just the way the surgeon, we call it enabling technology because it is truly enabling the surgeon, hopefully, through technology to do better work, faster work, more efficient work. But ultimately why that matters is because you're going to have a better outcome for the patients. And if we can improve outcomes in spine surgery, I think that's what we're all about. So, yeah.
If we can reduce radiation, reduce the time in surgery, increase accuracy, all those things. Some of the stuff I'm looking at, some of the stuff the industry is looking at, very, very exciting.
Yeah, and I think one more point, as the innovation continues to get better, it's not going to be costed out where many people don't have access to it because it's just so expensive. So I think that's going to be nice to see too, because I do firmly believe that the price point matters on something like this. And it's one thing if you're selling into a large academic institution, but I'm talking about the rural hospitals, the small community hospitals, the surgery centers, and let's not forget, it's a global market. So many of these countries, we've just priced out the opportunity for them to even participate in the enabling technology space. So I think that's going to be interesting too.
The top technology today is so expensive. Can we reduce those costs to the patient and the institution, provide more access to the global community?
Yep.
Love those comments.
Yep. It's a hot take.